All
All right,
right.
good morning once again, and welcome back to the NB Heart Center CV rounds. Today we have Dr. Duncan Webster from the Infectious Disease Department, who is going to provide us with part 2 on SARS-CoV-2. Last week we talked about testing, just sort of the logic and the logistics behind testing and diagnostics. And today we're going to talk a little bit more about testing, of course. There's been some interesting updates even in the last day or so on this particular subject matter. And then see if we can delve into immunizations and whether or not we, are we doing the best that we possibly can. So Duncan, I'm going to pass this over to you. Thank you.
All right. Yeah. Thank you very much, Ansar. You can hear me okay, eh?
Yep, no problems.
Great. Okay. Okay. Thank you. Yeah. So yeah, it's a pleasure to be back here today. After last week's talk, I had a number of questions from a lot of people about the testing, and so I thought it'd be a good opportunity, and based on some requests, to talk about testing again, and immunizations if we have time. So, given that we don't have a lot of time, I'm just going to fly through here. There we go. All right. So again, I want to again start by acknowledging the land that I live and work on, the unsurrendered and unceded territory and traditional lands of the Wolastoqey. And after last week, one of the notes I got was from Vern, and Vern had reached out to say, here's a couple links. We've got I got some questions about this, and rightfully so. I think when you see some of what's going on, you hear in the press and in the hallways, a lot of questions will come up, and I think they're really good questions and good things for us all to think about. So this was one headline that Vern had passed along. Millions of rapid tests sit in storage as provinces focus on other options. And there's a link on this website to a Health Canada site, which clearly describes high numbers of rapid tests. And some of these tests are tests that we talked about last week and that we have availability to in our province. So specifically looking at the 3 rapid tests that are described. And again, when we talk in the hospital setting about the rapid test, colloquially, we're talking about the Gene Expert, which is a highly sensitive and specific test. When we're talking about the rapid tests in this particular context, we're talking about the Abbott ID Now and the PanBio, which we talked about last week, and I'll talk about again today. And then there's another, the BD Veritor, which we don't have any of in the province, so I'm not going to talk about those. So if we've got close to 30,000 Abbott ID Now tests and over 250,000 PanBio, what about them? What are we doing with them? What should we be doing with them? So what I'm going to try to go through is a rational approach for the potential use of these rapid tests in New Brunswick, because as we've all seen in recent weeks, with the variants, this pandemic is far from over. And so we, I guess, as much as we would like to tuck this away and move on to other things, I think we need to keep talking. So just some review again with regards to the Abbott ID Now, which we talked a bit about last week. So again, it's isothermal RNA amplification. It is a molecular test, although not traditional PCR, and it targets the RNA polymerase. The data that we have for this is really very weak, and that's one of the big problems. When this test was originally coming out online back in the early days of the pandemic, there was a lot of questions about its sensitivity and specificity, and very, very poor sensitivity reported. More recently, Canadian data and some data elsewhere showing that the sensitivity may be a bit better than we had first thought, which is reassuring, but still the data that we're relying on is really weak. And especially from a cardiology perspective, when you guys are used to data talking about thousands of patients, and I throw up data based on 45 symptomatic patient specimens and 16 cases where collection wasn't indicated to determine a sensitivity and specificity, that's pretty weak data. I think we can all agree. Nonetheless, it does shine a little bit of light, and it gives us a bit of what we've got to work with. So I'm gonna come back to this and just again note that this is Health Canada approved for individuals with suspected COVID-19 within 7 days of symptoms. So one of the big questions about how we may want to use this test really is what accuracy do you need? What are you comfortable with? Because if you're not comfortable with some inaccuracy, then it's probably not where you want to use this test, because there are going to be inaccuracies with it. So let's just look at a few examples here. So coming back to that concept of the positive and negative predictive value that we talked about last week. So if let's say that we've got somebody for pre-op screening and they're asymptomatic, based on even our very low prevalence, which again is inflated for the sake of these discussions, the positive predictive value in this particular scenario is going to be 100% based on the current data. But that's based on very weak data, and again the prevalence will change. We'll get more data. When we look at the negative predictive value, and that's really, I think, if we're taking somebody in for pre-op testing, it's really the negatives that we need to trust. If we're wrong about the positives and things are delayed or people are overcautious, but I think it's the negatives that people really want to be able to trust. So in this context, can we trust a negative result? And I think, yeah, we can. We can trust this negative result with this Abbott ID now, but it's not because the test is accurate. It's because our prevalence is so low right now, and that's why we can trust this negative result. But as things change and our prevalence change, or situations from which the patient comes into the hospital, the prevalence can be considered different, and that will change the values. So as examples, what if we have somebody coming in from a long-term care home where we know 20% of individuals are positive, and so we apply that prevalence to the situation? What does that tell us about the negative predictive value? Well, it's 97%. So are you still comfortable with that? And what if we're wrong, and in fact half of the long-term care home are infected? So you have a prevalence of 50%. So now the negative predictive value is almost 89%. So one in 10 times that negative is going to be wrong. So are you comfortable for that? And as Ansar had made reference to, things have changed even within the past 24 hours. So at the present time, asymptomatic pre-op screening is not going to be required. But at a later date, when it is, asymptomatic patients, are we going to trust that? So what if we look at using this in a different setting? What if we think about a symptomatic patient and we're trying to determine, do we have to keep this person on infection control precautions? So again, based on our current prevalence and the sensitivity and specificity of what we have for this test, the positive predictive value is 1.8%. And as we talked about before, these are very, very low because our prevalence is so low. The positive predictive value is almost meaningless. The probability it's a false positive is over 98%. So really any positive that we're going to get with this test, we're really going to need to do confirmatory testing anyway. But false positives are okay if you're using it as a screening test. So with screening, you just want to rule out. So again, the question really becomes, can you trust a negative test? How comfortable are you with a negative result? And in this case, based on the data we have right now, symptomatic screening, and we want to take somebody off IPC precautions, the negative predictive value is 100%. But again, the data is so poor that it's hard to really trust that's personally. So let's switch this into a slightly different scenario. So let's say you've got somebody who you're taking to the cath lab, and they're coming from a local mill where there's an outbreak, and there's lots of individuals at risk for heart disease, coronary artery disease in local mills. So there's an outbreak at one of our mills, prevalence is 15%, and you're going to take them to the cath lab and you screen them with the ID, the Abbott ID now. Positive predictive value 71.3%. The negative predictive value is 100%. I don't know about you, but showing you the data on which we're basing this, personally, I'm going to feel better if we have better data. I'm not comfortable yet to use this ID now for prime time. So let's say we do some more local validation, and we find that in fact the sensitivity is not that 100% that we have based on the Quebec data, but it's actually much lower at 85%. So now the negative predictive value is 97.2%. So how comfortable are you to take this person to the cath lab, knowing that they're working in the local mill where there's an outbreak? How comfortable will you be? Let's say that it's somebody, from a family with international travel, and they come back and 6 of the 8 members of their family are known to be infected. So they're from within a household, and you screen them with the ID Abbott Now, and you get a negative result. And the negative predictive value here is just over 67%. So it's going to be right 2 or 3 times. Are you comfortable now? So I- I'm not sure I would be. I think if I was taking somebody to the cath lab and they were in a household with an outbreak, I don't think I would want to rely on this test and these predictive values. So I think the issue really is that this test really, we need a lot more data. So with the Abbott ID Now, at the present time, this test is being used at peripheral sites, and it's guiding decisions while we wait for other tests. So, as an example, it's being used in St. Stephen, but any test result is being undergoing further confirmation. So there is a plan to enroll us, and this is already happening at some sites. The Moncton Hospital is already starting to use it. The deck is ready. We're talking about how we are going to use this here. So it's going to be used to guide the IPC precautions in the emergency department. But again, the exact details here are still being sorted out. And from my perspective, my feeling is that really we need more data. The data that we have is not, the initial data that came out was very suspect about this device. The accuracy is in question. And although some data is showing it may be more accurate than we first thought, we really need more data. We really do. So it's something that I think we can use concurrently with our traditional PCR, build our data set, and understand with more certainty what our sensitivity and specificity truly is. So what about the PanBio? So you'll recall that this is the rapid test antigen detection, similar to a pregnancy test as we described last week. Very low sensitivity, and this is even with symptomatic patients, but a rapid turnaround time, very easy to use. So taking somebody to the cath lab under the current situations here today, using this test, again, the negative predictive value is fantastic, but that's not because the test is any good. That's because our prevalence is so low. We can trust the negatives because we have so few positive cases in our community. And the positive predictive value, as you can see, is really meaningless in this context. What about the case of somebody coming in from the local mill, and we opt to use this test to screen? They're symptomatic. You're going to take them to the cath lab. You want to know what precautions to use, and you've got a negative predictive value of 95%. How comfortable are you with that? I personally am not comfortable with it. I want to highlight this epidemiology of COVID-19 pre-vaccine era. A lot of the Canadian data that we have is summarized in this text. I was honored to be one of the co-authors for this Royal Society of Canada document. One of the things that we do highlight is that the screening and testing strategies are so important to how we respond, and we need to have optimal strategies in place. And the strategies that we will use they're going to vary. It's going to depend on the population that we're testing. It's going to depend on pandemic factors that are ongoing, and within a region or province at any time, you may apply different strategies, and you may change strategies as situations change. Very on in the very early days of the pandemic, you'll remember we talked a lot about the reproductive number, and we still are talking about that. That is very important. The concept of flattening the curve. And at the beginning, the point of flattening the curve was to protect the healthcare system. We knew from prior novel coronaviruses that once these viruses get into the healthcare setting, things go bad really quickly. So we wanted to keep it out of the healthcare system, out of the hospitals, and out of the long-term care homes. And that's still very important. We still need to be thinking about protecting our healthcare system. So in that context, how would we use the PanBio? I'll show you one place where it is being used outside of the healthcare setting. So this is in Halifax, where they knew that there was a lot of people in the nightclubs who were frequenting, and there were some contacts and some exposures there. And this was a setting where they were going to test people who were otherwise not going to get tested anyway. And this is a setting where it's outside of the healthcare system. So the accuracy is not critical. If you're going to detect a few extra cases and you're going to miss some, but you're people who aren't being tested anyway, have you really lost much? Not really. You actually picked up a couple cases you wouldn't have known about, and you've had the opportunity to educate at the same time. So using it outside of the healthcare setting. And I think really that's what's appropriate. So when I look at these tests, I think the PanBio, I think it's better than nothing in certain settings, but not a lot better than nothing, and certainly is not something that I would advocate for use in the healthcare setting. So in terms of rapid tests available in our country, one of these I would say do not be comfortable with this in the healthcare setting, unless you're comfortable with inaccuracies. With the ID now, I think it's reasonable to look at it more closely. Could be used for screening in certain settings, but we really need more data. And that's what I'm going to be proposing for local use, is that we implement this with concurrent traditional PCR, gather more data, and once we're more comfortable with the parameters of the testing, then we can really determine how to best use this test. All right. So I'll just comment that in order to understand how to use these tests as well, it's really critical that we know what our prevalence is. And provincially, we should be screening about 3,000 people, I would say every week. And most weeks we're in around that number. So I think currently our surveillance is not bad. Okay, so do you want me to run through some immunization stuff really quickly, or do we want to talk about?
Yeah, absolutely. No, I would.
Run through the immunization?
Yeah.
Okay, I think we've got about 10 minutes or so.
I would say, yeah, no more than, yeah, so 5 to 7. Just do a blitz version.
All right, here we go. Fasten your seatbelts. All right, so first of all, the mRNA vaccines, I mean, brilliant biology. Essentially, this is a new approach to vaccination, and what you're taking, you're taking RNA that's been constructed to encode for the antigen of choice, wrapping it in a lipid nanoparticle, and injecting it, and you're going to allow antigen presenting cells to present to CD4 and CD8 cells, and you're going to boost humoral and cell-mediated response. It is brilliant technology, and it's played out really nicely. When we look at the Pfizer vaccine, again, as a blitz, we know that this is 2 doses of 30 micrograms intramuscular, three weeks apart, 95% protection with 2 months of follow-up. And this is based on about 40,000 patients randomized, and 170 cases of COVID-19 were identified, 162 in the placebo group, 8 in the vaccine group. I mean, incredibly effective. The things that we don't know, we do know, of course, we've got the issues of storage with this vaccine. Requires ultra cold freezer storage until it's taken out to use. What we don't know is if it's going to prevent people from carrying virus without symptoms, and that's going to be important. You may be able to prevent disease, but can you prevent further carriage transmission? And does it prevent severe cases and death? The numbers are still really low from the study, so time will tell. And again, the follow-up is short, so how long will its efficacy last? These are the questions that remain. The Moderna vaccine, again, very similar RNA technology, 2-dose regimen as well, 100 micrograms, 28 days apart. The COVE trials showed that it was, again, just about 95% effective, and none of those who received the vaccine experienced severe illness. So highly effective. What the trial doesn't assess, again, asymptomatic infection and the ability of the vaccine to lower infectiousness. So these are really critical questions in terms of understanding how the vaccines may um, help to slow down the pandemic. I think this slide really is the blitz itself, right? I mean, the data from these two studies are so good. And as it says, a statistics tip that I personally like, always try to get data that's good enough that you don't need to do statistics on it. I mean, this graph just speaks for itself. It's incredible how effective these vaccines are. Safe, well tolerable, but again, effectiveness, what we see in studies, and the efficacy that we see, the efficacy that we see in studies, the effectiveness that we see in the real world, we don't know. And generally in these vaccine trials, patients were not all that frail, and so it's a different population. So we'll see. And population-based studies will be coming. The AstraZeneca vaccine has gotten a lot of press lately, and of course, it looked very good. A vaccine effectiveness of 82.4% vaccine efficacy. It's a different type of vaccine. It's a live vector vaccine, but again, safe, well tolerated, great vaccine efficacy until, of course, we get into the variants. So we've got our UK variant, our South Africa variant, our Brazil variant. These are the ones that are getting a lot of the press right now. The UK variant still looks to be, looks like the AstraZeneca vaccine may be still effective against this lineage, although there's some questions now being raised about whether or not it may be more virulent. The South African and the Brazilian variants are really where we start to question, especially with the South African variant, the efficacy of the AstraZeneca vaccine. Even with the Pfizer and Moderna vaccines, the data is not clear yet. It looks promising. And the nice thing about the mRNA vaccines is that a simple change to the sequence, and you should be able to solve that problem, although it would still require further studies. So I do want to just quickly mention one other recommendation that was made in this RSC document in terms of vaccine allocation. And I do think this is important. How we use our vaccine, we really need to have a standardized case epidemiology and outbreak tracking to inform policy on vaccine allocation. And I guess what I mean by that is, who gets the vaccine? Every strategy that you'll see will put the long-term care homes at the top of the list. Absolutely appropriate. So NACI, the National Advisory Committee on Immunizations, a great group. They've got a stage 1 and a stage 2 approach at the present time. It needs to be hashed out. Most provinces at the present time have something that looks more like this. This is Quebec's approach, which you can find online. Again, you've got long-term care homes, and then healthcare workers working with vulnerable populations at the top of the list. But then it largely starts to go down through by age. Now, I think an approach like this is a good start, but I do think that it does need further granular and thoughtful approach here. I'll just give you one example. If we look at the age group 60 to 69, and this is data from Ontario during the first wave, the crude fatality rate was 5.45% for that age group. Now, if you look at data that's come out of the UK, these are individuals with Down syndrome. And when you go through, they present hazard ratios, but when you look through the data and try to compare it to the Ontario data, the crude fatality rate amongst this population was 73%. So are we going to feel comfortable to vaccinate a healthy 65-year-old and not vaccinate a younger individual with Down syndrome who may have cardiac anomalies and the like? Again, I think we have a good start in determining prioritization, but I think we really need to have some further thoughtful dialogue about how to best distribute, because this really is one of the classic medical ethics issues: distributive justice. We've got more need that far succeeds our current supply, and in the coming weeks, we are going to have an influx of vaccine. We are going to be using vaccination aggressively. So I think we need to think carefully about how we're going to use. All right, I'll stop there.
That's awesome. Duncan, thank you so much. Couple of questions just for me, and then obviously people can share stuff on the chat, and then as we did last time, even text you or / message you offline. Two questions. One is around just the overall reduction in rates that we're seeing now, in whether it be in Canada, the US. There's been a sharp decline. From your standpoint, what are the drivers behind this? And the second feature, it doesn't really apply in Atlantic Canada, but is there a role, and I think you kind of just zinged over that slide there, but it may be worthwhile going back to explore the concept of herd immunity, especially as it applies to the United States and provinces with higher prevalence rates.
Sure. Yeah. Thanks, Ansar. Yeah. The answer, I think, to the first question, why we're seeing a decline, it does come back to the primary mitigation strategies that have been implemented from the very beginning. Masking, social distancing, hand washing, cleaning of shared surfaces, focusing on well ventilated areas, within when you're indoors, and doing what you can outdoors. Those are the primary mitigation strategies, and now vaccination is the new mitigation strategy. I think the big thing that we're seeing in terms of the cases starting to decrease, a lot of it is due to the lockdowns and the decreased movement, and certainly international travel. So all those things, it's those primary mitigation strategies that are having impact. And with regards to herd immunity, yeah, thanks for asking about that. So it's interesting, the threshold in terms of what's been discussed is the sort of herd immunity that's required. The percentage of immune has been slowly increasing over time. And one of the things that it has pushed this more recently is this concept of these variants. So we're now talking about an immune population that is closer to 90%. So that's what we talk about when we talk about measles. So vaccination is going to be critical, and we really need to prevent transmission. And remember that reproductive number. What we need to do is push that down below 0, and that's what allows us to get to herd immunity.
Colin asked a question about the ability of the vaccine to prevent severe illness from COVID, number one, and then I would follow that up with people who've had COVID already. Where do they fall into the vaccine priority scaling?
Maybe
Yeah.
if I could just clarify the question for you, Duncan. The ability of COVID to prevent severe illness, and if someone gets if you vaccinate everyone, and a few people get mild illness, but no one gets severe illness, how important is that, and contextually in the whole kind of scheme of things? So if it doesn't prevent all COVIDs, but only those cases only you get are mild, that
Yep.
equally is important, I would think as well. Maybe you could share your comments on that.
Sure. Yeah. No, I think that's a really good point, Colin. So we don't know how much it's going to prevent severe illness. So, example, I mean, if you look at the mRNA vaccines, the Pfizer, Moderna, there were so few cases that it's hard to kind of pull out and say, is it going to decrease severe infection specifically? But it did look to prevent, because those cases that were identified were not severe. So it does look to be effective in that respect. The AstraZeneca vaccine, that's one of the concerns, is we don't really know that the population that was studied in South Africa, as an example, thinking about the variants, this was a younger population. So we didn't see severe illness, but is that because the vaccine was effective in preventing severe illness? Or is that because the cohort that was studied, it was a younger cohort that's less likely to have severe illness? So it's a good question, but it looks like it should prevent severe illness, especially the mRNA vaccines. And I think if we accomplish that, from my perspective, I think that is a excellent objective. I think, from many respects, mission accomplished. We want to keep the healthcare system from being overwhelmed, and if we're preventing severe illness, then I would say that we're doing that. So I think that would be, with it, from my perspective, quite acceptable.
The follow-up questions are as follows. Number one, the Israeli vaccination program has been obviously one of the highly touted ones because of the sheer volume of vaccines that they've delivered. Is there any follow-up data, as per Craig, on the Israeli data as it relates to viral shedding and transmissibility post-vaccine? And then JF asks, and this would be our last question, will there potentially be any role, as, because I'm sure they're not mutually exclusive, but there's potentially some overlapping capabilities of vaccines, of double vaccinating people or even triple vaccinating people to take advantage of all the differences that do exist.
Yeah, thanks. Great questions. So yeah, the Israeli experience is pretty remarkable. But the question being, what does that say about transmission? Nobody has that data yet. So we're all waiting to look at this. We are a long ways off, I think, from clearly identifying that data, but we don't know. And that really is one of the big questions about these vaccines. Can they prevent illness? Yes, they look to be highly effective, but what about transmissibility? And we just don't know at this point in time. So that is one of the really critical points about approaching herd immunity. And then the other question was with regards to different vaccines and combining them. So there is talk about that. In New Brunswick, I've been an advocate personally in my discussions to say that what we know about the Pfizer and Moderna vaccines shows that they're highly effective, 94, 95% effective. We should use them as they were outlined in the study, because then we know what we're doing. As soon as we deviate from those studies, we're really not sure what we're going to get. Other jurisdictions, other provinces, countries are doing things differently. They may be giving a single dose, hoping that they can give a second dose later. I think in other settings, desperate times call for desperate measures. In New Brunswick, we're not desperate. Our situation is very, very good. And I think we would be unwise to use vaccines outside of how they're defined in the studies, because then we really don't know what we're getting. Now, that being said, there is already talk about people deviating from studies, and there's talk about down the road using different combinations of vaccines. So that data will come. How that will look, it's hard to say, but I suspect that we will be happy with the effectiveness of most of these vaccines. But again, the variants really throws a loop into this. Anything that we thought we knew about COVID-19, we're almost back to the beginning with some of these variants. So it's a complex situation.
Duncan, thank you so much. I think we've all learned a ton. The feedback has been tremendous. There was over 100 YouTube views for your last talk, and I imagine it will be just as good this go around. Thank you for taking the time to prepare this and to sit down with us. I'd love to kind of put a save the date on you for later in this year, because this is a topic that will really never grow old, even if we're tired of it, personally. But I think we all want to know more about it, and knowledge is power when it comes to this particular disease. So thank you for sharing your knowledge with us, and in doing so in a manner that, makes us all smarter for it. Thank you so much.
Yeah, I really appreciate the opportunity. Thank you.
Thanks, everyone.
Take care.
Next week, Zlatko will speak on the subject of management of the borderline ascending aorta. So it should be a good talk. Thank you so much.